This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome back to Audible Bleeding. Today, we're excited to have Dr. Gilbert Upchurch on as a guest for the show. And I'm here with my fellow hosts from Audible Bleeding, Dr. Alozzi and Matt Smith. Dr. Upchurch is the Edward R. Woodward Professor and Chair of Surgery at the University of Florida College of Medicine and the 2019 President of the Society for Clinical Vascular Surgery. He completed his general surgery residency and vascular surgery fellowship at Harvard's Brigham and Women's Hospital and his endovascular fellowship at the Cleveland Clinic. He is an accomplished translational scientist. As a reflection of his prolific career in research, he presently holds 4 active NIH grants for studies examining the molecular basis and gender differential for aortic aneurysm formation. He's also active in clinical practice and has contributed to the advancement of endovascular technology via multiple device trials. He is an associate editor of Rutherford's Vascular Surgery and has given over 400 invited lectures, which include 150 visiting professorships. In addition to his impressive track record as a surgeon scientist, he has used his academic leadership roles as a platform for mentorship and education. He has won numerous awards as an educator and takes a particular interest in adapting education to the learning needs of a younger generation of surgeons. Welcome to the show, Dr. Upchurch, and thank you so much for being here.
Thanks, Nicole, and everybody on Audible Bleeding. You're really doing an amazing job. Thanks for pushing us forward in vascular surgery.
Great. Well, we're really happy to have you on. Looking forward to this discussion. I just wanted to start by asking you some of your thoughts on mentorship. You know, you're known for your role as an extremely supportive and effective mentor to multiple young vascular surgeons. I wanted to know if you could describe what you think it takes to be a good mentor and talk about some of the mentors that led you into the field of vascular surgery.
Boy, is that the whole hour? Or I'm just kidding. That's a great question. I spent some time between undergrad and medical school, and I was exposed to both George Johnson and Bowers Simpio. Bowers been at Yale for a long time when I was at North Carolina, and even before starting medical school, I had sort of great role models in vascular surgery. And I set my sort of surgery residency fellowship up to work with great people like John Manick, Andy Whittemore, and Mike Belkin at the Brigham. And then I took my first job and worked for a guy named Jim Stanley, who I still think is like one of the quintessential surgeon scientists, was also president of the SVS and editor of the JVS, as well as current therapy and surgery. So I have to say all along the way, I sort of picked role models, and I think that's just really important. I sort of used my transition from medical school, residency, fellowship, et cetera, and then into practice to always sort of surround myself with people that I wanted to look like. So I think that's really important. In terms of my own mentorship style, I would say that I have no formal training in education. But the key, I think, is to really be passionate about what you do. My co-interns used to say, I did every other night call for I don't even know how many years, but my co-interns used to always say I was the guy who whistled on his way into work because I was just so happy at 4:00 in the morning to just be going and taking care of patients and operating, et cetera. So I think, you got to just have a passion for what you do. I got a text from a kid that we helped raise when we lived in Charlottesville, and it was at 5:30 this morning. And the question he asked me was, "Why do you work so hard?" And of course I was up, and I texted him back and I said, "I think it's because I get great satisfaction in doing a job well done." And so maybe you could say that I'm not very efficient, but I think I am a really good multitasker. I think those are all really things. I think that the mentorship there, that the article that I quoted from Jen Walge in my SCVS presidential address, I use that presidential address as an opportunity to learn about how to go about being a good mentor. And to be honest, different people require different things, and so you got to sort of be open. We talk a lot about mentorship, but there's also coaching, there's also sponsorship. And not everybody needs mentorship, but everybody needs some component of one of those three things. This morning, some of the young faculty and some of the residents are running for committees at the Association of Academic Surgery. And, here I am early in the morning editing op notes and stuff at work, but I just took the time to sort of put their name out to the faculty here at the University of Florida, say, hey, if you're an AAS member, please consider these people for committee candidates. So that's not really mentorship, but that's really more like sponsorship. So all three of those things are important, and you can use different people for different things. So,
yeah, Dr. Upchurch, maybe you could elaborate for our listeners a little bit about what you see as the difference between mentorships, coaching, and sponsorship, because there's some overlap. But what do you see as the differences?
Well, I'll give you an example that sort of in my role as a chair of surgery that one of the things that was really needed here at the University of Florida, and that was we had not done a good job, and this is true to this day, we had not done a good job of sort of projecting ourselves out. And what I mean by that is we didn't have people going up for appropriate honorific societies. We had not had papers necessarily on at big national meetings, et cetera. And so going about the business of sort of organizing on a yearly basis of who to put forward, who's deserving, how I can help promote people, that's not really mentorship. That's more like sponsorship. So that's sort of, for me, defines sponsorship. Coaching, I say, is I'll use the people that work in my lab as an example. So this is something that I've done from the very beginning, is people who work in my lab that spend 2 years dedicated basically to understanding pathogenesis of aneurysms. One of the things I do for them, or I try to do for them, is but when they're done, I will go out and buy them interview clothes. I will buy either an interview suit or, for both males and females. And I'll go out and talk to them about their 2 years in the lab. And mainly I'll talk with them about what they want to do and how I can help them, applying for fellowships and stuff. That's more like coaching. And I'm trying to help them put their best foot forward by looking professional and helping them decide about which places they need to apply for, et cetera.
Had anybody ever done that for you? I mean, that's a very interesting, I'd never heard of that, but that's a very interesting and I think very generous use of your time. Has someone done that for you before? Or?
Yeah, it's so thoughtful of you.
I don't really remember anybody doing it, but I feel like, you ask people to spend 2 years in your lab, let me say, I have very strong feelings that it's really people who work in my lab. It's great, but I think it's really more about the individual. So I'll say this time really should be your time. And if you choose to work in a lab, that's great. If you choose to get a master's in education or an MPH or go do global surgery, it's really more career development time. And I try to emphasize that when people come to interview here. But no, nobody really had done that for me. I just sort of felt like, it's 2 years of your life. And it was the 2 years I spent in the lab were like the best 2 years I ever had. But, I ran a marathon, I lifted weights, we had 2 kids, I published a bunch of papers, I traveled the world giving talks and stuff. So it was such an important 2 years to sort of galvanize the fact that I wanted to do academics. I enjoyed sort of the academic life. But no, I just started doing it. I've been doing it for over 20 years now, and I just think it's important. It's a way, to be honest, to say thank you. 2 years is a long time to have somebody dedicated to you, and I've not always done the best job of sort of being a good coach or helping them. In fact, it's so interesting. I would say a full 75% of people who've worked in my lab have not gone on to become vascular surgeons. So you could say that I wasn't a very good mentor, but I was a great coach because I helped them to decide they really wanted to be an anesthesia resident or something.
Dr. Upchurch, this is Matt Smith. Can you speak, a lot of times we talk about mentorship and everybody assumes we're referring to, medical students and junior residents and et cetera. Can you speak as to the importance of mentoring people at the next level, junior faculty, outgoing fellows?
Yeah, we do something special at Florida. I was taken back this year. We had 2 finishing fellows, and I think this just speaks to the fact that mentor to me means family, which means yesterday, one of my young faculty partners was doing a case. The patient was really large. It was a hard case. He was struggling. He said, "Hey, do you mind come over here and helping me and I just walked, I was doing a case in another room. I walked over and sort of helped him. And, that's obviously one form of mentorship. And to be honest, my role at the University of Florida has changed. Now, I've always done that. I did that at Michigan. I'd come in the middle of the night if somebody was doing a rupture AAA and they felt things weren't going well or whatever. That's an easy thing to do. But one of the things that we do at Florida, which I was just blown away with this particular year, is we have a dinner for the finishing fellows. And this will speak to mentorship being family and forever. So we basically stand up and give the finishing fellows presents from each faculty person. And these are really meaningful and important presents. I mean, sometimes it's a 12-pack of your favorite beer from a Gainesville distributor, but other times it's and the fellows give the faculty a present. I was so blown away by it, but this past year, the fellows gave sort of individualized Yeti coffee cups, which I drink. And so mine says 2 snaps and a tie, which is what I always say when a case goes well, or how easy it is, how easy vascular surgery is. And everybody on this phone call knows that vascular surgery is not that easy, but and we give the fellows individual presents from each one of the faculty members. And it is really so meaningful. So that's really important and that's really nice. But I think, to be honest, I've heard from both of our finishing fellows, and I hear from finishing fellows all the time, "Hey, can you take a look at this case?" This past Tuesday or so, this was a remarkable day. I got CT scans from 3 past trainees or partners asking me to look at them and sort of see what I would do. And, one of them was like, "Would you be willing to take this patient on?" But I think that is mentorship, isn't it? I mean, I don't, when somebody who's either in practice or a finishing fellow has the trust in you to sort of want your insight into a complex clinical problem. And I think, mentorship means family. And I think that's a really important thing. It doesn't go away just when you move from institution to institution.
That sounds like you guys have a really great tradition there for the outgoing fellows, and that you really certainly do have a lasting bond with them. One question from the perspective of someone who's, a junior fellow right now, what are the qualities that you seek in a trainee or a mentee?
So it's really interesting. I think, we all want to believe that we work really hard. And I would say, I know this is going to sound really simplistic, but the first thing you got to do is try, and you got to work hard. And I know that sounds like, sure, that's a given, but that hasn't always been the case. We all were surrounded by people, medical students, undergrads, and where they're like, "Yeah, I'm just not willing to do the work that it takes." And I think just the fact that somebody puts the effort in, I think for me, there are very few of us that are natural surgeons. I'm left-handed, but they would not, at the Brigham, they would only teach me how to operate right-handed. And so, you can imagine my first year as an intern, how many times people were like, "You are challenged." And, and ultimately I think, I put in the reps and I did the work, and now very few people tell me that I'm challenged in the operating room. In fact, I use the fact that I can sort of operate both left and right-handed completely to my advantage. And I love to bedazzle the fellows sometimes by starting to sew left-handed when I've been sewing right-handed all the time. But anyway, so I think, just the effort is critical. Almost everybody, there are clearly people that are better endo and people that are better open. I've sort of always tried to as a full professor at the University of Michigan, I went and did that fellowship at the Cleveland Clinic in 2006. And because I didn't feel like I was giving my patients a balanced approach. I was I was endovascular. I was a little bit of an endovascular phobe.
Doctor, at what stage, you were a full professor, so how far into your career were you when you went back to the endovascular fellowship? How many years out?
7 or 8 years. 7 or 8 years as a faculty person.
And how long was the fellowship?
3 months. and I was away from my family, and I was away from, I already had an I think I know I had already, it was at the end of a KO8, but yeah, I was a named professor at the University of Michigan and felt like I was doing some endovascular, but I wouldn't say I was very endocompetent. And then I went back and did that fellowship, and I came back, and since then I've sort of been able to give what I think is a more balanced approach. And I think that's critical. I think that's one of the things that a lot of times, when I first was a faculty member at Michigan, everybody was seeking endovascular training. And then after about 10 years, everybody was seeking open training. Like, oh, yeah, of course, everybody can do an EVAR. And so it's sort of interesting. I have to say that one of the things and pride's not the right word, but I think being sort of an endovascular, I say I'm an endovascular moderate, because I can do both open and endovascular and sort of look at the patient and try to sort of assume. And I think that's one of the great things about vascular surgery, actually, is that a lot of people are endovascular moderates. They can do both open and endovascular equally as well. And some of my contemporaries, like Dan Clare and I Dan Clare was at the Cleveland Clinic as a professor when I went there, and he and I trained in general surgery together at the Brigham. But he and I now, when we meet and talk, we sort of often have sort of a reflection about it, how we used to do everything endovascular, and now sort of things are sort of swinging back. And, sometimes maybe a good aortofemoral bypass in a young person who's going to live for another 20 or 30 years may be better than iliac stents. And so I think that's one of the important things I've learned through 20 some years of a career, is that there are swings. They're open, endovascular, and vascular surgery. Quite honestly, we're on the cusp of it. One of the things I just learned yesterday, which is really interesting, I was either going to be a cardiac or a vascular surgeon, and the chief of cardiac surgery, when I told him I was going to do vascular, said, here's some lead over here. You put that on because that's all you're ever going to do. And I heard yesterday that the cardiac surgeons are really struggling because all the fellows can do TAVRs, but none of them can actually do open aortic valves replacements. And so it's so interesting to hear them sort of beginning to have a discussion around, their own fellowships not getting enough open aortic surgery. I thought that was ironic.
All right. So Dr. Upchurch, maybe we'd like to transition a little bit. I think this lends up to our next topic, which you addressed in your presidential address to the Society of Clinical Vascular Surgery, which was recruitment of millennials to vascular. And it's, I think you laid it out well, but maybe you can speak to why we need millennials and how to engage them.
Well, I think the why is pretty simple, right? The why is we don't have enough vascular surgeons. We're going to be, in the next 10 years, we're going to be something like 800 vascular surgeons short of really the requirement, with the graying of society, increased obesity, increased diabetes, the need for a person who can do what I just described, that is, have a balanced approach. And the balance also includes offering medical therapy, optimal medical therapy. And so I think there's no other specialty that can do that. I think that's clear. So the why is pretty clear. We're well trained to take care of patients with all vascular disease. And I think that's something no one is ever going to take away from us. So that's really important. I think that vascular surgery in particular, there are a couple of things that I would point out. One is that people who go into vascular surgery are creative. They, in general, like operating all over the body. One day you'll be doing a bypass. The next day you'll be doing a stent. The next day you'll be doing a patch. And so there is between the sort of multi disease processes we treat and the multiple anatomic areas we treat, people who go into vascular surgery are creative. And I think that's a really important thing. The second reason I think millennials are completely well equipped to perform vascular surgery is, and it's sort of linked into sort of the creative, but innovation is really highly rewarded in vascular surgery. We need people thinking about better ways to perform operations. We sort of know now that an endovascular approach initially at least affords patients for aneurysm repair, lower mortality, lower time in the hospital, fewer blood transfusions. And if you ask the patient, do they want a blood transfusion, they will all say, of course, no. So, and while I know that the mortality lines sort of parallel and cross at 2 years, I think that's been a really good thing. We need young people thinking about a better way to do vascular surgery. And so I think that's where millennials have a heads up, and they embrace technology. They don't sort of shy away from it. I'll define it. I have a fellow, he's now a faculty person at, and we were doing a carotid subclavian and doing like a zone 1 arch in a lady, which is, this sort of a complicated case. And as we were doing the bypass, he goes, well, why don't we do a right carotid to subclavian bypass and then just reimplant the carotid onto it? I'm like, because that's just not the way it's done. You do a carotid, and then you do a carotid subclavian. And then I started thinking about, now this was like 5 years ago when not many people had done, a lot of this. And then I started thinking about it. I'm like, well, there's one less anastomosis. There's like less plastic in the neck. And then finally I was like, okay, let's do a right carotid to left subclavian bypass and then reimplant the carotid on it. And it worked out great. And I just think part of it was just sort of him thinking of a better way to do it. And it turned out it was a better way. So that's just an example of, and, here's the thing. I had to be open to listen to him because, we're as vascular surgeons, we're pretty, I do a carotid endarterectomy exactly like Andy Whittemore did a carotid endarterectomy when I learned it like 23 years ago. So in general, we're not really early adapters. We're sort of late adapters, but I think the creativity and the innovation are critical, and millennials have that in spades.
Dr. Upchurch, how do we reconcile kind of this idea? Millennials are generally known for having a little bit better appreciation for life-work balance than some of us, and they want to live in urban centers, et cetera, et cetera. How do we reconcile this with the need for more vascular surgeons, out in far-reach communities where they're on call 24/7. They're the only ones out there.
Yeah, it's a complex issue. I would say that. Oh, I love that in the back.
Speaking of life work balance.
By the way, I would say this: you should totally embrace that, because I look back when we had 3 boys of our own and raised a couple other. When my kids were little, Sunday mornings when I was off, which was not very much, were a reserve for Dunkin' Donuts, and my wife could actually have a shower without a bunch of kids sort of draped all over her legs. But so please embrace that. It's and it sort of ties into your question, which is how can you say we need more vascular surgeons, and yet the number of hours people are willing to work. I just think that speaks to the fact that we need to be creative about our training paradigms. And it's really interesting. People have not really embraced the 4+2. There's very few people who are programs that actually, I know we have a bunch of residency programs, but if you look at the data, we've sort of gotten to about 140 or so programs with combined fellowships and resident programs. And we've sort of plateaued off again. So once again, we've sort of hit a spot where the training of vascular surgeons is sort of plateaued. And we need to figure out some more creative ways. And the higher level systems, the Vascular Surgery Board, the RRC, the ACGME, need to sort of embrace that we need to train more people and need to help us adopt those changes. Now, I have to say something. One of the things that Nicole didn't mention is I'm chair of the Vascular Surgery Board. And so I don't want anything that I've said to sort of be construed that I'm speaking on behalf of the Vascular Surgery Board. So I just thought I would throw that little non sequitur in there.
So, Dr. Upchurch, speaking of life-work balance, one of the things that you discussed in your presidential address was burnout and how prevalent it is in the field of vascular surgery. Some of the numbers that you cited were that 25 to 40% of vascular surgeons drink alcohol daily, 29% withdraw emotionally from families and friends. We have a demanding job and people are prone to getting burned out. What do you think are the kind of strategies that we can use to prevent burnout, or changes that we can make to the field to prevent us as a field from kind of going down that path?
For me, I've moved to a place at the University of Florida where we have a really strong team of doctors, and we're all pretty much our practices. I mean, there are people who are better open surgeons than me, and probably people that are better endovascular than me, but we're all capable of providing sort of the full gamut of vascular surgery. And if we're not, then there's somebody around to help. So I think one of the keys is to be part of a group where you're not the only one who can do a fenestrated endograft or a complex open thoracoabdominal aneurysm. And so that you do actually can take a break and you're not obligated. We have the closest thing to a group practice here at the University of Florida that I've ever been in. Now, people work incredibly hard, and Tom Huber, the chief, is like the hardest working guy I've ever known. I'm not saying that you're still not at risk. His presidential address from the SAVS a couple of years ago was just about burnout. But I think having a team whereby you I would say in the old days, I still go in I work every Saturday, but in the old days, my first stop was rounding. I would go round on all the patients I had operated on the week before, and I used it a little bit as a sort of a social just obligation to stop in and see how patients were doing and make sure they were okay. But now we have a group practice and somebody else rounds on the patients. I can round on them as well, see how they're doing. But I think that's a really critical. Now, we're in a big, large academic medical center. Somebody said, well, how about the person out in a small city, a rural area where, they're the only one within a couple hundred miles that can do vascular surgery? I just think that speaks honestly to the fact that we need to look at our training paradigms and both train more vascular surgeons, but also think about new training paradigms. I'll refer you. I don't know if you guys have interviewed Macaroon from Pittsburgh. He gave sort of he challenged the vascular community to think about this workforce shortage in sort of a creative idea of 1-year fellowships and not necessarily doing thoracoabdominal aneurysms, et cetera. But I think we have to be open to sort of new ways of training. And so I'm going to transition to sort of how we can recruit more millennials. I think that was one of the questions that I may or may not have asked. I think one of the keys is to enjoy what we're doing. So, if they see us, there are many studies that have shown that vascular surgeons spend the most time in the hospital because we're both in general, we're both the medicine, the surgical, the radiologic care of patients with vascular disease. But if they see us in the hospital all the time and we're miserable and we don't like our partners and we're not kind to ancillary staff and faculty, then who wants to go into that specialty? So it sort of is a nice segue back to the original question, which was about mentorship and sort of role models. So I think we just have to. I have this thing about some of my lowest days are when I've sort of either hurt my institution or hurt my specialty by not being a positive role model in various settings. So I think that's just really important. I know it's complicated, and I haven't really given you any granular ideas about my thoughts on this, but I think it's a little bit of a moving target this year. And I'll give you an example. This year in general surgery at the University of Florida, when I first got here, we'd only have like 3 people going into general surgery or vascular surgery. We have some people matching in directly into vascular surgery. This year we have like 10 or 12. So I think part of that is just the sort of the renewed enthusiasm about being a surgeon. There's a lot of really positive things about it.
Dr. Upchurch, can you speak a little bit to some of the things you touched on in your SCVS lecture on flat leadership structure and reverse mentoring and micro mentoring and what these things mean?
Yeah. So the reverse mentoring, I think you guys just saw a great example of that when you coached me through how to get on Ringer right before our conversation. I mean, that's a classic example of, I'm capable of doing it. I'm 58 years old, but you're more capable of coaching me through that. So if I'm obstinate and not open to your teaching me how to do that, and I just think, so I think that's really sort of a classic example. The flat leadership thing, I think, is really, listen, I don't want to undersell the importance of time in the job. I mean, I've been a faculty person for 21 years. That's worth something. And, I've seen more. And so I don't want people to think that I don't think experience is important. It's critically important. But I think that the flat leadership thing is really interesting. I think, use of technology is something that's sort of driving the way we learn now. And a lot of times, people my age don't embrace technology. I think I'm actually more savvy electronically than my actually own kids. And so I think for me, I made it seem like I was sort of coming to this conclusion that I personally have become a millennial, but not by birthright, but by sort of action. And I think I'm a total multitasker. And I think that plays into vascular surgery. The fact that you can be an expert in ultrasound, that you can be an expert in medical management of peripheral arterial disease, that you can be an expert in open surgery, that you can be an expert in endovascular. And the fact that you have so many options, younger people like that. My dad was a dentist, and he went and he practiced in the same small town for 52 years. And he went and did the same job every day. People don't do that anymore. They don't like that. Following fellowship, I moved from Michigan to Virginia, and I've moved from Virginia to Florida. People want to actually have some upward mobility. They want choices. And I think that's really important. And vascular surgery is I think it's the greatest option for people who like choices. Especially in terms of vascular surgery content. I think that's just really critical.
Dr. Upchurch, I would completely agree with you. I think one of the cool things about our field is the scope of the operations that you do and the scope of the type of practice that you can have and how you can adapt that. As you age, you can start off doing bigger cases, and then as you get older, kind of, do more small outpatient come and go procedures. So there's a lot of lifestyle benefit to a field that has that kind of a diversity of practice. So I think that's a great point. I wanted to transition actually to an idea that you mentioned in your presidential address about creating a video book for vascular surgery, kind of modeled after what the thoracic surgeons have done to create kind of a living document that has interactive materials for kind of a new generation of learners. Can you comment on that?
So, that hasn't been ferreted out quite so well, but I think so first of all, I know that I personally, I hate to say it, but when I go to the operating room and I haven't done something for a little bit of time, I basically pull up, and I don't want to use a brand name, but I pull up something on the internet and I look at a video. I just think that is just the way people learn these days. And if I'm, and I think, so that's part one. Part two is people just don't carry around books. And I'm in the process of generating another textbook for a big, I'm about ready to be the editor of a really big textbook. But so I don't want to be critical of it other than to say people just like learners, and I include myself as a learner, they just don't carry textbooks around anymore. They carry their phone. And so clearly the ability to go to your phone, pull up a chapter, pull up an app, look at a video is just the way we learn. It's just it's a given. And so I think we need to adopt our learning to that. I've been thinking about this for over 10 years. And as I was coming up through the Society of Clinical Vascular Surgery, I used to always say to myself, well, if the SVS has Rutherford, why don't we put together a video book? Like, why don't we make a video book? And I wasn't able to really sort of make good on that. But I do think in the next 5 years, I was the chair of the publications committee, and I know I've had conversations with the executive director at the SVS. I know that we're going to redo Rutherford. That's coming in the next couple of years. I think we can use Rutherford as a platform to then subsequently link what are important papers, videos to Rutherford and put it and make it a much more downloadable learner interface. I just think that's the wave of the future.
Yeah, that would be great to have.
Yeah, especially if it's something that's peer reviewed.
Yeah, it's something that's a little more interactive, where the actual references to the material you're reading could be like readily available. Because I've tried to, like click directly on the links to the references in Rutherford's, and you kind of hit a stone wall where there's some publication page that you need to log into, and it's just not easy to use. So that's definitely something that needs to be developed.
Yeah, I think that's absolutely.
The other side of that is that there is a lot of content out there, but it's not necessarily peer reviewed and adjudicated to be good. And so it'd be nice to have some guarantee that what you're seeing is judged by your peers as valid.
Absolutely.
Right.
So, Dr. Upchurch, there are a couple of questions we like to ask our interview subjects often, because I find that I learn a lot from these. One of them is there something that is true that you know to be true that most people would disagree with you on?
So one of the things that I've sort of studied in the lab for a long time, and I think Nicole sort of touched on it in her introduction, was this gender differences in aortic aneurysms and sort of how we could, and I know that to be true. We've done it in mice, we've done it in rats, and we've done it in pigs, and we know it's true in humans. So there's something different about aortic aneurysms and males versus females. And I think it's really up to us to not only better understand it, like we can do all the physiologic experiments, understand all the differences in the receptors, et cetera, but then how you translate that into medical therapy to help humans with the disease, I think is a really important thing. And then the second thing that I know is true is that aneurysm pathogenesis is very complicated, but nature is not. So what that means is that we don't understand it. Nature is not a bunch of circles and, it may be feedback loops and stuff. And so in some ways, I've spent my entire career understanding sort of the acute processes and animal models and stuff. And I think ultimately, we need to start thinking about all of vascular disease as sort of chronic diseases rather than acute diseases. And so maybe the therapies that actually will be most effective will be targeted in once we start thinking about, for example, the resolution of inflammation and blood vessel healing rather than the acute events. So those are a couple of things. Those are a couple of insights from 20 some years in the laboratory that I think I can provide that other people may not really know.
Dr. Upchurch, can you offer any advice? As you know, a lot of our listeners are junior fellows or early faculty members as to incorporating research in your early career and how one gets going on that, especially if you didn't have as much experience during training doing it.
Well, so the first piece of advice is get it early during training. But I hear you. So especially as a basic scientist, and there are fewer and fewer and fewer of us. So I'm not. You got to sort of do it all along the way. But, you may not have the time. You may not feel like you have the expertise until it becomes too important. So this is what I always tell young faculty. If you really want to put yourself on an accelerated course, you have to blend your clinical interest with your research interest. And so if you're interested in aortic aneurysms, then, and I'm not talking about just basic science, I'm talking about health services research. I'm talking about the business of healthcare. I'm talking about the impact on at-risk populations. If you're interested in aortic aneurysms and performing aortic aneurysms, then write papers about patients with aortic aneurysms. Ask that your division chief make you the PI on all the aortic endo trials. so that your name is a sort of and I'm just talking about it in terms of aneurysms or aortic disease. It can be done in venous disease, PAD, whatever it is. But I see the people who have the most bang for the buck have this sort of blending of their clinical interest with their research interest and educational interest. Because what happens is people will say, oh, well, Nicole's an expert in fibromuscular dysplasia and renal vascular hypertension. Let's get her to write a chapter on that. And so what happens, and let's have her give a talk on audible bleeding on this. And so, it really spectacular things happen academically when you merge your clinical and your research interest, because then that helps you parlay it into educational interest. And so I see people moving fastest and getting promoted most rapidly, not because they're basic scientists, and some of them are basic scientists, but mainly because they merge their clinical interest and their research and educational interest. That's when sort of the symphony is all playing together. Your academic career sort of takes off.
That's really fantastic advice, Dr. Upchurch. One thing we like to ask all of our guests is if there's a technique that's gotten you out of trouble in the operating room that you could share with us.
When I was at Michigan, there was an interventional radiologist named Dave Williams and a cardiac surgeon named Mike Deeb. And I learned more about aortic dissections from them than I have anybody in my whole career. But Mike Deeb is a cardiac surgeon, and cardiac surgeons, it's sort of interesting. Vascular surgeons always sew from the inside out, but cardiac surgeons sew from the outside in. And Mike Deeb also transected aortas and always used felt reinforcement. And I have to say that I do that. And I put in very few repair stitches. So I'll sew to some completely degenerated, a pararenal aorta using felt reinforcement and almost never put in repair stitches. So I learned that from Mike Deeb, who's a cardiac surgeon. I think that's a good technical tip, using felt reinforcement around the aorta. I don't know how many vascular surgeons do that.
It's funny that you say that, Dr. Upchurch, because I was at Sinai for my training, and I learned a lot from Ollier about open aortic surgery. But one of the things I learned from Griep is exactly the same thing: is transecting the aorta, and I use felt on all my proximal anastomoses for that very same reason.
Yeah. I didn't experience that in training, but I learned it from a cardiac surgeon, and I use it all the time. And I try, and when I do it with a young faculty person, they're like, "Whoa, that is so nice." Until, of course, you get into a big, huge lumbar vein on the backside of the aorta, and then you're not thinking it's such a great idea.
Dr. Upchurch, do you listen to music in the operating room? If so, what do you listen to?
I listen to country, but I'm willing to listen to whatever. One year I had the most proper Indian guy who was a fellow with me, and I'd say, well, let's put on what Amit wants to hear. And I'd say, what kind of music do you listen to? And he listened to like historic Indian music. So we listened to, I'm not exactly sure. I could even tell you what the name of it was, but if it made him feel better and so faster, then that's what we listen to. So I must say, I don't know that I've ever asked an anesthesiologist what they want to listen to, but I definitely ask the fellows or the scrub nurses what they want to listen to. So remember, I've got young kids that are between the age of 25, 21 and 26. I grew up with an iPod that had rap on it and thunder rock. And, those are really interesting. Mac Brown is back at Carolina as a head football coach. And he was when he was at Texas. He felt like he was disconnected from his football players, so he went. And this is in the days of I don't even know you'd record all the music on an whatever, and he got the same music put on his iPhone or that Vince Young, who was the quarterback of Texas, who led him to a national championship, listened to, so that he would sort of connect. And I think I try to do that as well.
Dr. Upchurch, this has been such a fantastic discussion. Thank you so much for joining us today on Audible Bleeding. It's been really great chatting with you. Thanks,
Nicole and team. It was great. Now here's the key. So did you guys know that game day was in Gainesville today?
No.
So that today I'm literally walking out. So just to show you that I have a good work-life balance, I'm walking out of here and going over to the Auburn, Florida and you're going to love this. If you come to Florida, we have a Department of Surgery wellness event before every home football game that involves tailgating and food and drink. And the whole department comes together, including the residents and the fellows. And then Florida plays Auburn at 3:30. So there will be some wellness going on today at the University of Florida.
Wow, that sounds like so much fun.
Just to prove to you that I'm keeping my work-life balance appropriate.
This is Audible Bleeding. We'd like to thank all of our listeners who've contributed to support the costs of producing the podcast. Specifically, we'd like to thank Dr. Hernan Bazan for his very generous donation. And we'd also like to put a call out for videos, as our conversations with Dr. Upchurch have inspired us to start a video book for vascular surgery. So if you have great operative videos that you think would benefit the rest of the community, send them our way, let us know, and we will work on curating a collection that everyone will have as a resource and we can host on our website. You can find us at audiblebleeding.com.